I did it already. Right. I did it when you start talking.
Oh, you
Me for free any cancer tissue on prostate biopsy because it was after initiation of treatment. So I'm going to be doing a bone biopsy. Could you, Bill or Rick, speak to the tissue and, since mutations are currently, constantly occurring, how often should you have this done to be sort of most current with the mutations that are most treatable?
Boy, oh boy, that is another really good question. And I'm not sure that anybody knows the answer. What is known is that tumors evolve rapidly with time. And so, that means that, the answer you get this year might be different next year, and there might be additional mutations that are actionable. Once again, meaning, I know that you know this, but for the others, meaning that there are drugs that will potentially act in concert with a mutation to kill tumor cells. So how often should you do it? I don't know. If you have the money, I would, I really don't know the answer. I guess if I were Donald Trump, I might do it every year. I really haven't thought about it, but that's a really good question.
God forbid.
So I'd like to just say one thing on the money, which is that if you don't have the money, or you think that the insurance company is not going to cover it, give a call to Foundation One, because what we've heard, Steve heard this a while back, and now we've had it confirmed from other people, is that Foundation One is back charging the pharmaceuticals. So if you cannot afford to pay and you let them know, they're going to try and find a way to get you sequenced. And I want to tell everybody not to be discouraged and not get sequenced because of money, because the chances are you will be able to find a way, and I'm happy to help you and to guide you. And I'm so frankly, I'm just really devastated by the fact that we didn't get Trevor sequenced as early as we should have done. And believe me, it wasn't for want of my trying. But the doctor was resistant and sat on her hands, and by the time they futzed around and putzed around and found something that they wanted a biopsy and got, I don't know, it was too late.
Yeah.
And I can't, I don't want to see this happen again. I don't want to see it happen to anybody, and especially anybody that I work with and who is on this call.
I am also really concerned about this, partly from my own experience. Right, it was very difficult for me to convince my oncologist not to do the germline sequencing that we did, because I didn't care. I was going to get it done no matter what, and they knew that, and so they just signed off on it right from the start. But if I had not been a colleague, they would have put up a battle, and even though I am a colleague, they just weren't interested in, once I had the sequence information, it was unbelievable. They were still unwilling to learn what it meant and how it might impact my treatment. And therefore I had to go out and, track down the lap rib and make the arrangements for it. And so, I'm not complaining here. I just want to reinforce what Rick is saying about how you really need to be proactive with your oncologist to push this forward. And, if you have, yeah, go ahead, Rick.
The other thing, sorry to interrupt, but the other thing that your point you made, which was a very good one a month or two ago, was that I think a lot of oncologists don't understand germline versus somatic, and
right.
The incidence of even BRCA in somatic mutation is much more significant than the 1% to 2% you see in germline. So even if you don't, right, you're not born with that genetic hereditary component, it certainly could have mutated on this somatic level, and that may make you a candidate for PARP inhibitors as well. So I think it's important to understand that just because you weren't born with BRCA like Angelina Jolie or you, doesn't mean you can't have it.
Yeah, okay. I hope that I also, made that point strongly. But thank you for emphasizing it. It is critical to understand that this is something that everybody who, I think anybody who has prostate cancer should be pushing this very strongly, but especially anyone that has advanced prostate cancer. And if you run into troubles convincing, if anybody on this call runs into trouble convincing your oncologist that they should use this approach, let me know, and I will help with the argument. I can be very persuasive, especially when it's something that I really care about. Well, and the point about finances that Rick made, that also is very much worth emphasizing. You cannot let finances become a barrier to doing this. I've also heard that Foundation One is making arrangements for patients to obtain the sequence information at no cost to them. And I think, I can predict that this is going to become much more common. The standard business model for Foundation One, and there are a number of companies that are just getting going. There's one that called, I think, Grail, that Bill Gates invested heavily in just in the last couple of months. And their business model does not include the money that patients pay for the sequencing. It's through other mechanisms, and that is driving down the cost substantially, of course.
So let me hold on one second. What I want to do is take some time for questions. So whoever it was that had a question, we're going to go right to it. Bill, you'll hear in this conversation tonight about a situation exactly as you described, where we have a recalcitrant oncologist and we don't know what to do. So,
right.
So we'll come back to that, and we'll come back to it relatively quickly, but it's on the agenda for a discussion with one of the gents who's on the call tonight. So let me go to questions. Who I don't quite know how.
Okay.
I've got one.
Can I, before we start questions, can I make one more quick point?
Please.
And that is that another way to get your tumor genome sequence is through, of course, clinical trials.
Right.
And there is the NCI match trial that you asked me to look into,
right,
Rick,
right,
a couple of days ago. Is
right.
Certainly one. I mean, they're recruiting thousands of patients, and they will sequence their tumors and then match any actionable mutations up with the appropriate drugs. And so that definitely is something you should look into as another way to get your genome sequenced. It's also something that you're going to have to be even more proactive on, because many oncologists won't help you. Once again, I can help you. Contact the appropriate people that are involved in the clinical trial and get the ball rolling.
I will just say on the match trial that the gent who is going to be talking to us about immunotherapy did get back to me, and they expected to have a whole number of prostate cancer people in their arms and in the various arms of the trial, and in fact they've really only had one guy that they've had any success with. So I do want to just point that out. So I
saw that email, and I don't understand that.
So can we go to questions?
Yeah, I've got a question.
Please.
Yeah, this is Peter. This is Bill. This is a little bit futuristic, but it kind of relates to the Angelina Jolie situation. I mean, she did not have cancer, but she was proactive in getting her germline testing done.
Right.
So a situation like I have two sons in their 40s, and this is the third generation. My father died of prostate cancer. I've got an aggressive form of prostate cancer.
So the day will come, I'm sure, where people will do germline testing before the horse is out of the barn. And my question, I guess, is it logical for a prophylactic approach to have a prostatectomy, say, in your 50s, if you suspect, if the evidence shows that you have a proclivity to prostate cancer?
Absolutely. Your son should have their germline sequenced. It's likely that there will be mutations that are responsible for your tumor and that would cause tumors in your son. So I would encourage you strongly to tell them that they should, go to a genetic counselor and make arrangements to be sequenced. As far as, prophylactic approach that involves surgery, if you do find a mutation before you contracted cancer, I know of at least one person who had his prostate removed before he ever got prostate cancer. But I think it's not as common as with women and ovarian cancer or breast cancer, especially ovarian cancer.
Bill, as a gynecologist, I did 3 or 4 prophylactic laparoscopic removal of the ovaries, and the tubes need to come out too. The fallopian tubes are likewise in BRCA at risk. But that's you're in and out of surgery in 2 hours, and there's minimal risk. Radical prostatectomy is a whole different bird. And I would say, my own experience, I just went through stereotactic radiation of the prostate, 5, hypofractionation sessions, pretty benign. And I would certainly, if you're going to do something prophylactically, I would much more lean towards that because of the less morbidity.
Right. Yeah. I mean, but then there's, breast cancer.
Yeah, breast is another story. I'm talking ovarian and fallopian, but radical prostatectomy is an extremely morbid procedure.
Yeah, I would not. I hope no one has mistaken me to be encouraging anyone to take that. There is just one person I know that went that route, but I certainly wouldn't have done it.
Yeah. Do we have any other questions from anybody on the line?
I have a question, Greg. This is Jake.
Please.
Hi, Jake.
Hi. As you were talking, I was looking at the Foundation One site, and they mentioned you need a biopsy sample.
Yeah.
What if you, in my case, my biopsy was like 5 years old, and the last one didn't show any cancer in my prostate.
Yeah.
How would they sequence it if they don't have anything to sample?
Well, yeah, if they don't have any tumor cells to sample, they're not going to be able to get a sequence. But you must have had an original biopsy.
I did, but it was 5 years.
Tumor. I'm sorry?
It was like 5 years ago, and the site says it's probably too old.
Who told you that it was probably too old?
Well, the site said. I mean, they said the more current, the better. They recommend getting a new biopsy if possible.
Yeah. Okay. That's understandable, but it is the case that they can sequence DNA from formalin-fixed tissue. This is a pretty harsh treatment that fixes the cells, before the pathologist reads the slides. And it's now possible to recover enough DNA to sequence even from a slide from a biopsy. Which is very little, very few cells and very little DNA. So I wouldn't let that stop you.
I don't require 30% tumor. They require 30% cumulative tumor mass, cancer tumor in the sample, even on a slide, though. And if it's 5 years old, it doesn't seem that relevant. I wouldn't act on something 5 years old. That's just old data. Things have changed.
So,
right.
Let me throw something in here. Let me throw something in here. I tend to agree with Steve. I mean, because people that have more advanced tumors, and those of you who are not responding to treatment or are responding relatively quickly. I mean, people on this call, like Ron Shaheen, for example, or or maybe, I don't know, we haven't had an update from Tom Gary in a while, but there are, you know who you are. I mean, you're just not getting the mileage out of your treatment. If that's the case, then that cancer is on the move, and you want more recent samples. Now, what I heard from Tom Harding, who's the gent that's going to be talking to us about immunotherapy, and I don't know how true this is that Foundation One is getting the capacity, or may already have the capacity, to sequence circulating tumor cells, which are the cells in your bloodstream, the cancer cells in your bloodstream. Now, we know right now that Johns Hopkins has the ability to do that. But whether they have the panel or what sort of panels they have, because I don't think they're in the dream team, that I don't know. But if we can get blood tumor cells in our blood sequenced, in other words, you take a tube of blood, and in that tube of blood, if you have advanced cancer, there are probably some cancer cells swimming around, and they can be removed and extracted, and they can be analyzed. That is going to be a significant improvement and a much easier way to get biopsy. The other thing I want to say on that too is, for those of you who still have a prostate and haven't had it radiated because you were diagnosed late and you had no primary treatment, that prostate can be biopsied. What we have learned in the last 3 or 4 months from a study, which I'll put up in a minute, by Peter Nelson at Fred Hutchinson, is that within the same man, about 90% certainty that all tumors have the same genetic composition. And that is really important. It means if you take a sample from your bone or your prostate, the chances are it's going to be very similar. Now, every man's tumor is different. I mean, it's such a heterogeneous disease, but within that person, you're probably in pretty good shape. So now you can be somebody like Steve, who, thank God, because it seems like the chemotherapy has worked, the tumors in his prostate appear to have gone. He still has tumors in his bones that we can biopsy. Or you can have the unfortunate situation that Trev had, where they did take a biopsy, but they couldn't use it for whatever reason. I don't really understand, and they sat on their hands about doing a bone biopsy. But there are ways around the biopsy problem, Jake. I think you had original treatment, didn't you?
Yeah, I had cryotherapy. They froze half of my prostate.
Yeah. But if they only froze half of it, if the other half is still healthy, they may be able to take a biopsy out of that. I don't know. It's one discussion.
Rick,
it has to have cancer in it, though, right?
Exactly, 30%. You can't. In other words, a normal prostate biopsy is going to help you. And the other thing, just incidentally around CTC, I had a discussion with Andrea Hartstark about this. She says they're at least a year away from being able to gene sequence on circulating tumor cells. At least a year, she said.
Mm-hmm. Okay. Thank you.
That's really pushing the technology to the limit at this point, because there are so few, usually so few circulating tumor cells. Mm-hmm. I'd like to just go back to a point that Rick made, and about old versus new. Of course, a more recent biopsy will give you a more accurate picture, but mutations that were there at diagnosis aren't going to go away.
Oh, okay.
And if you can't for some reason get material from that's newer, from a metastatic lesion, for example, I still think it's worth going back to the original biopsy. I mean, this is something that I'm faced with at the moment.
Okay. Do you have a prostate, Bill? I can't remember. What was your? So
yes,
maybe
I do.
So maybe they can. Maybe you can get something out of your prostate. You can get a sample out of your prostate.
They have the radiologists and oncologists have told me that there's nothing left.
Oh,
that
okay.
the radiation treatment was so effective, and the
Okay.
drugs, that there's just, they can't see anything.
Okay. So
And
does anyone else have a question? Does anyone else have a question? Because I want to leave some time to get to, you know, for the regular part of our call. But if anyone else would like to ask a question who hasn't already asked, please go ahead.
How do you spell the name of that drug, olaparate?
OL.
Okay, it's spelled O, L as in Larry, A, P as in party, A, R, I, B as in boy.
Oh, okay. Wasn't there an article about that in the latest hot sheet for August?
There might have been. I haven't looked at the hot sheets for a few months.
Right, and
There might have been.
I haven't either. It's also called. It has a commercial name of Lynparza. I think
Yeah,
it,
that's that.
Lymparza.
Yeah, that's in the latest hot sheet for August.
Okay,
The mutation suggests new prostate cancer options.
there you go.
Okay, so another point that, you know, I think is worth emphasizing is that, you know, this is targeted therapy at its best,
Mm-hmm.
and it is working incredibly well for me. I mean, I was told a couple of years ago, I had one of my oncologists look me in the eye and say, Dr. Burhans, I don't expect to be seeing you here a year from now. And here I am. I'm pretty much healthy as a horse, except for the cancer.
Okay.
So this approach really is incredibly powerful.
So Bill, I think the other point that sometimes is missed, you know, those of us especially been on sort of shotgun chemo like docetaxel and so on, you know,
Right.
It doesn't have all the side effects because you're not killing every other cell in your body basically. And so, I mean, fatigue, anemia, yes, but it doesn't have the array of side effects that the traditional chemo does. And so that's a huge advantage.
Yeah, that's a good point. Thanks.
Okay. Anyone else? Or shall we move on to individuals? Okay. Well, listen, Bill.
If anyone has questions in the future, feel free to contact me.
Right.
Through the Inspire website, or Rick can give you my email address.
I will be happy to. And Bill, thank you so much for doing this. I know this is not the best time of day for you, and we so appreciate it. So appreciate it. Thank you. Thank you.
Sure, I'm happy to do it, and I'm actually feeling pretty good this evening.
Good, good, good. So I'm going to run down. I'm going to run down the list. I don't know if we'll get to everybody today. We're going to kick off with Mike Tamales, but I want to find out who has something that they'd like to raise tonight. But forgive us if we don't get. I hope everybody's found this hour pretty helpful. Eric, do you have anything for tonight?
Yeah, I have a couple things.
Okay. Jake, anything for you?
No, Rick.
Okay.
I do want to make a point. I posted a note on the chat. Foundation One does have an RNA option.
Okay.
Apparently, $2,800 extra.
Oh, okay. I think that's probably something new since December. So thank you.
I just went on there today for the first time, and that's what it said under the patient.
Okay, that's probably new. I'll let Larry know that too. Dr. Steve, anything for you?
No, you know what's going on with me, Rick. I think I'll just hold off on that. And also getting my first haircut tomorrow in 6 or 8 months, and I want to look like Eric when I'm done. Eric, do you think there's a chance?
Well, you know, if we've got time, you know what? I would like you just to let people know where you are, because there's some significant change, and I think you deserve the time. And so, but you can just give people a 2-minute update because it's significant. Oh, sure. Okay. Tom Gary, are you still with us? Tom Gary, are you still with us? I guess not. We may have lost him. Paul Frieder, anything for you?
Nothing for me tonight, thank you.
Okay, Jim Cameron, how about you?
Nothing for me either, Rick. Thanks.
Okay, Peter Kafka, how about you?
I'll pass tonight.
Thanks. Okay. Bill Franklin, for you? So, no Bill Franklin. Dennis Correa, anything for you, Dennis? Do you want to give us a quick update? Dennis, you still with us? Okay.
Yeah, I keep forgetting to hit my mute button here. Yeah, I could give you a quick update later.
Okay, you'll give us a quick update. Let me just check. Bill Franklin or Tom Gary, have you got your mute buttons pressed? Okay, if you've got your mute buttons pressed, you can take them off and interrupt me if you've got something you want to say. Ben Gulo, anything for you?
No, nothing for me. Thanks very much for the information.
Sure, thank you. Jim.
Great.
Jim Harrington, anything for you?
No, nothing for me, Rick. Thanks.
Bill, is there anything, Bill Burhans, anything you want to talk about for yourself for treatment?
I don't think so. If anybody has any magical way to deal with mostly neuropathic pain, I'd be happy to hear about it. But I don't, you know, other than that, I don't have any issues.
Okay, so if we can talk, we'll leave neuropathy till the end, but if we've got any time at the end, we'll come back to neuropathy. Ron Shaheen,
Okay.
Ron Shaheen, anything for you? Ron, are you still with us? I don't see. It looks like we've lost Ron Shaheen. Rich Catapano, anything for you?
No, I'm good. It's an interesting show, though.
Thanks. Paul Hobson, are you still with us?
Yes, I am.
And anything for you?
Brief update.
I'm sorry?
Hello?
Yeah, we're here.
Brief update.
Oh, brief update. Okay, excellent. And Paul, let me just ask you very quickly. Do you know how you can get Foundation 1 testing in Australia?
Probably by sending samples over to the US.
Okay. Okay, I just wondered if you had any experience. I need to get back to Alex Ziem on that. And Tom Van Zandt, anything for you?
I'm buying stock in Zytiga right now.
Okay. Oh, you might think about Foundation 1. All right. So let's kick off and spend a few minutes with Mike Tamales. Mike, either you or Peter or both of you between you, just give us a brief update of what's going on, and what I'd like to do is see if we can encapsulate the problems you're having with your medical oncologist and see what sort of suggestions we can make to help you.
Yeah, I don't know where to start. I was on half a dose Zytiga.
Can you get a little closer to the phone, Mike? It's hard to hear you.
Better?
A little better, yeah.
So I was on like a half a dose of Zytiga. Lowered it to 30, and I kept doing the half dose, and then my PSA went up a point from, I believe, 39 to 40, and they're recommending me to go to Zytigo as quickly as possible. Just blood work. The blood work is good now. And they're saying that the longer I wait, the blood work is going to get worse. And that I should go for it right now, but I'm back on the fence again.
You know, Mike, we're having a heck of a time hearing you. Do you mind if I ask Peter to summarize? Because I think we've got a better connection with Peter.
Okay.
Oh, that was good. What happened? That sounded
good, yeah.
You just got very strong.
Oh, okay.
Now we're
good.
fine. Now we're fine.
Now,
Maybe
just
with a push of a button will do.
there you go. Perfect. Just summarize for us again. I believe what you said is you're on a half dose of Zytiga, and your PSA has plateaued.
No, it was on a half a it was on a half a dose, and it went down 30 points, and then I left it a half a dose, and then it went up a point.
Mm-hmm.
And so we're gonna try to do the full dose and see what happens with this blood work. In the meantime, my blood work's okay now, but they're kind of pushing me to do this as soon as possible while my blood work is still good.
Mm-hmm. Mm-hmm.
And that's kind of where I'm at.
Peter, you want to do you want to elaborate at all?
Yeah, the oncologist is suggesting that Mike starts Xofigo, and Mike wanted another month to see if he went to the full dose of Zytiga, whether it would make a difference. So we'll know more about that at the end of this month. The scans he had indicated a significant spread in the bone issues, bone mets, with no soft tissue involvement. And the other issue is we've asked the oncologist several times about whether he would be a candidate for early chemo. And this guy's resistant. His takes the attitude that chemo is only needed or only used when there's spread to the soft tissue and there's organ involvement, and or is the last treatment possible. So he does not he's not aware of the work on the mainland with early chemo, or he's not interested in it.
So for those of you who don't know, Mike and Peter live on Maui, and so their choice of doctors is heavily restricted, and this guy is behind the times. So my question to people out there is, and maybe particularly for somebody like Dr. Steve, how do we pressure the medical oncologist to get up to date and to present all the options that are being offered here? And frankly, Mike Tamales is exactly the type of guy that should get gene sequenced right now.
Well, Rick, let me just say that he needs a second opinion and a third opinion if they don't like the second opinion. Mm-hmm. And if you're on Maui, I worked in Honolulu for a number of months, years and years ago. It's not state of the art there, I'm telling you. At least it wasn't when I was there. And so I would think it's a trip to UCSF or somewhere on the West Coast, UW, and get a second opinion from somebody that knows what they're doing.
Thank you, Steve. Anybody else want to contribute? Don't be shy.
Well, this is Eric. I really didn't hear anything you said except that he was having peripheral neuropathy. Is that correct?
No.
Okay.
What we're really talking about is, I mean, Mike has his bone mets are extending. The Zytiga may have worked its course. We're not quite sure yet. He's moved up from a half dose to a full dose. It was tough for Mike to tolerate a full dose originally, and the medical oncologist is resistant to chemotherapy, early chemotherapy. He believes it should only be used at end stage. So, you know, to even have a conversation with him about genome sequencing, I'm not sure where that's going to go. So I'm just asking, does anybody, Steve has given a really good suggestion, which we've also said, to get a second opinion on the mainland, because it can mean the difference between life and death here. I mean, I don't want to put it mildly, Mike, but, you know, you could have a long life in front of you if you got the right treatment. And we're asking, does anybody else have any suggestions as to how to deal with a recalcitrant medical oncologist?
Change oncologist.
Well, what do you mean by recalcitrant? You mean someone who won't do what you ask them to do, or I'm sorry, I had to step out for a few minutes.
By recalcitrant, I mean somebody who rejects ideas. He's been, chemotherapy has been suggested, and it's something that he believes is only used when the disease spreads to visceral, to organs, to visceral mets, or at the end of life.
I've dealt with a lot of doctors like this over the years, and I mean, there's some doctors that haven't read a journal in 15 years, and that's probably who you're dealing with. And you know, you need another doctor. You just need to find another. Even if it's on Maui, there must be somebody, or UH hospital, or somewhere in Hawaii, there must be somebody that is more current, because this guy is not going to help you at this point.
Peter, go ahead, Mike. Hold on a second. Go ahead, Mike. Respond, please.
He's supposed to be in charge, but he's the one that knows the less, or gives me the least time. So I keep I keep a urologist in there anyway, because he'll take the time to explain stuff to me.
Yeah.
Can your urologist suggest someone else?
There is nobody else.
Oh.
Unless I go to Honolulu.
I would go to Honolulu. I mean, you know, it's a short flight. That's what I would do.
Probably a good idea. Yeah.
Is that not possible to go to Honolulu?
Yeah. Go to Honolulu and see and see what doctor the
Do you and Peter have the same oncologist?
Oh, just find a different.
Who do you go to?
No, I go to Dr. Turner in Marina Del Rey.
Oh.
Yeah. I mean, anywhere in the West Coast, you're talking 4 or 5 hour flight. Is, you know, it's worth the trip one time for sure.
And
I go with Mike to his appointments, and when the switch from Lupron Casodex to Zytiga came up several months ago, I immediately asked about the ARV7 test to make sure this was a worthwhile try, and the answer I got was it's really not worth it to us. We're just going to go to Zytiga. If that doesn't work, we'll go to enzalutamide, If that doesn't work, we'll do the next thing. So right now they're suggesting Xofigo, which is not the same. And to do Xofigo, Mike would have to fly to Oahu once a month for the shot for that. And he's got to check to see if his insurance will cover the flight, because it's not offered here on Maui. There's no facility to do nuclear medicine like that here for the shot.
Yeah, you need nuclear medicine for Xofigo.
I mean, how can we get Mike sequenced? How has anybody got any ideas how, with a doctor like this, we can try and arrange to get Mike sequenced? Does it mean we've got to get him over to the mainland to arrange for sequencing? Or because to me that there's, I have a feeling that we're going to find some things in your gene sequencing. That's just a gut feel.
It should be possible for him to get his tumor genome sequence without going to the mainland. I mean, all it, if there's any, material, biopsy material, then it just needs to be sent somewhere. But I guess the big question is whether or not there's any biopsy material.
Well, the bigger question, Bill, is if their doctors are not willing to work with that, even if you have a result, nothing is going to change. I really, as a physician for 35 years, he needs another doctor.
Yeah.
Not just another opinion. He needs another doctor.
Right.
I guess the urologist might be a place to start, to see if the urologist would
good point.
To do the gene sequencing.
Great point. Very good.
It's just a matter of sending the slides, and if it'll be covered by Foundation One. But even if you have mutations that are specific, it doesn't sound like his oncologist is going to act on that.
Yeah, that's what I wrote to Peter earlier on today, and my concern.
There's physicians that we call past their expiration date, and it sounds like that's what you got, basically.
Well,
we got a few advocates like that too, by the way.
Yeah, I know.
This guy's not terrible. This guy's not terrible, but he is a general medical oncologist.
Yeah.
I mean, he deals with a whole gamut of cancer issues,
Yeah.
and I don't think he has the time or the interest to specialize.
Well, look, I think that we've given you and Mike some good suggestions. My strong recommendation is the two of you sit down sometime this week and you try and come up with a plan. But, at the end of the day, it rests with you, Mike. And if you really want to get things to change, there are ways you can do it. And they could make just an enormous amount of difference to you. And I think everybody on this call encourages you to do what is needed. But at the end of the day, you're the only one that can call the shots.
Right, that's right.
Can I get a number?
For a number for
a referral?
We can give you numbers for referrals, yes. But Peter can help you with that. I can help you with that. But talk to Peter, because we can start working on getting referrals. If you want a referral into UCSF, we can make that happen quickly. If you want a referral into Peter's oncologist in Marina Del Rey, we can make that happen quickly. But the answer is yes, we can do that for you.
I also, since you're in Maui, I mean, you're 30 minutes away from Oahu. University of Hawaii has a major medical center there. I would just go there and say, I want to speak to a urologic oncologist, and see who you can make an appointment with. You're talking a 30-minute flight. It's not that big a deal.
Urologic oncologist?
A genitourinary medical oncologist is what you want. Genito, G-E-N.
Well, that's the English pronunciation. It's genitourinary. Outside of Wales.
Okay.
Get me confused here, guys.
Yeah.
G-U medical oncologist.
Just say G-U.
I'll write it all. I'll write it all down for Mike. I'll meet with him.
Okay. Let's do it that way. Meet with Peter. Let's see if there's a GU med-onc at the University of Hawaii. That would be the best thing. If there isn't, then we'll go from there. Okay?
It sounds like a plan.
Okay. Eric.
Okay.
I'm going to move on. Eric, you're up.
Rick, thank you.
Pleasure.
Okay, so I'm about to start the BET inhibitor trial. They just put me off a week because they said I had to be off enzalutamide for 29 days, originally they told me 14. So I have to wait actually another 10 days. But within 2 days, I had tests at my regular cancer center, and UC did all their tests that were preliminary to being on the trial. And the PSAs came out at a point different. So, I mean, I know you guys have talked about how the PSA can vary, but I don't know, it just seems like, that they got, let me bring it up again. So my regular oncologist got 5.78, and UC got 4.81. I guess the thing is, that that's the first time I've had it done at UC, and so I have a record, with presumably the same processor and all that at Berkeley. So it's a dramatic increase. I'm curious as to whether anyone thinks that it was because I stopped the enzalutamide, or that it's, I mean, it was going up anyway. In January, it was like 0.03, and now it's almost 6. So it's just been going up, every month it goes up a point or so. I guess that's why they decided that the enzalutamide maybe wasn't doing any good anymore, and why I'm going on the trial. But it's confusing and kind of scary to watch it happen. So, I mean, the most my PSA ever has been was 6.5, and I'm already almost at 6. So I'm definitely on the way to passing that. And, my guess is by the time I start this study that I'll be, well over that. So I'm kind of starting to question whether I really should be in the study, since we don't, it's only a phase 1B, who knows what it's going to do. I don't know. Anyone have any opinions?
So let me just throw in a couple of things and then open it up. I mean, the first thing is that you're never tied into a study. I mean, you can go and you can walk out of that study anytime you want. Secondly, we know that the PSA is rising. The doubling time. By the way, for those of you who are saying, well, I don't get this. What is it? Eric's PSA is only 6. That's not a big deal. Well, some people have serious disease and don't make much PSA. And usually the people that are in that category have disease which is very variant. And as we know, this disease is very heterogeneous. So just because the PSA is so low doesn't mean that the disease is not aggressive. And what Eric's looking at is the incremental change, and the incremental change is significant. And I think that's what your doctors were looking at. And as Bill has said in the past, Bill Burhans has actually said in the past, and he may want to comment on this BET. This is the Zenith. This is the Zenith drug, Bill. This BET inhibitor. That the way that it works could be very effective for men that don't do well on abiraterone and enzalutamide. So the fact that you're accessing a drug which may have great potential, I don't know that I would want to walk, if it were me, I would want to walk away from that. So those are my comments. I'll throw it open to anybody that wants to talk about either what Eric might consider, or the BET inhibitor drug?
Yeah, by the way, Rick, I want to add that, I have confirmed tumors T1, 2, 3, 4, 5, and 6, and perhaps in lumbar.
So you faded right at the end there, Eric.
I may have tumors in my lumbar spine.
Okay. Go ahead.
Rick, this is Jim Harrington. Eric, would you just repeat again, what is the trial? You're on Xtandi now, enzalutamide, and your PSA is going up, and what is the trial?
So, Rick, you were really clear about it. You want to explain it?
Yeah, the trial is it's a drug made by Zenith. I'm going to post it. I know that won't help you, Jim, but I can send it to you later. It's a
no, I might, because I'm failing Xtandi too.
Okay, it's a BET inhibitor, and and my understanding, and I attribute this understanding to Bill Burhans, is that one of the things that this does is this drug crowds out the androgen receptors, so that they cannot feed. Bill, are you still with us?
Yeah, I am, and I'm blanking on BEG. Sorry.
BET, Zenith. Yeah, we talked about it about a month and a half ago. It's a drug made by Zenith, and it's a BET inhibitor. So it's a drug that might well work for people that are failing abiraterone and enzalutamide. I'll post.
Yeah, I'd like to know more about what is this. Is this coupled with immunotherapy or not at all?
I don't think it's an immunotherapy drug, but I'm not sure.
No, I mean, is it coupled with an immunotherapy? Sometimes.
No, in this study, this is only a phase 1B. It's not coupled. It's actually coupled with enzalutamide. But since I'm already failed on enzalutamide, I will be in the group that gets the BET inhibitor only, and there's another that's getting it in combination with enzalutamide.
Oh, I see. What are the side effects?
They said that they're very rare, that they don't have. They so far have not had a lot of trouble. They've only had a 1A, but they know it doesn't kill anyone.
So
that's good to know.
I'm sorry, Rick. I just been totally blanking on this. I'm going to try to do a quick search here, and
I've never heard of it either.
We had
yeah, you can Google. Right up if you Google.
We had correspondence on it, Bill. I'll send it to you later.
Yeah. Okay. Yeah.
But if you go to clinicaltrials.gov and you put in BET inhibitor or Zenith, you'll find it.
Okay. B as in boy, E
as in Edward, E as in Edward, T as in Tom. Yeah, BET inhibitor. Okay.
Yeah. Now I'm vaguely remembering it, but it still is going to take. I'll be ready to talk about this next week.
Okay.
Or whenever you have this call again.
Perfect. Anybody else want to say anything to Eric about?
Oh, it's a bromodomain. Yeah. I'm sorry. I'm remembering what it is. Yeah. Okay. It's a bromodomain protein inhibitor. Yeah. Okay, but I'm still going to have to refresh my memory on it.
Okay.
I'm sorry.
No problem. So, anybody else like to say anything to Eric about should he go forward with it? Shouldn't he go forward with it? What to do? What about the fact that his two PSAs are variant by 20%?
The PSA is being variant at two different labs. That's within lab error. These analyzers are not exactly calibrated the same, so I wouldn't think that those are necessarily different. Very nice. I like it. To me, Eric, it seems like, what do you got to lose? In a sense that, you can, like Rick says, you can drop out of that trial whenever you want if it's not working, right? Where would you go if you didn't do it?
They also said that if it is working, I can stay on it as long as I want. So
right.
the study's over,
I don't this is Bill. I don't see any drawbacks to going into the trial. And now I'm remembering what this was all about. This is a really promising approach, you know, this class of drugs. So, you know, it might be real useful to go on it. What's the downside that you see to going on the trial?
Well, it puts off getting any other treatment. So, you know, in the meantime, you know, the cancer grows and gets beyond other treatment.
Oh, okay, right. But you've been through enzalutamide and that's failed, and your options are pretty limited. I mean, I think if I were you, I would go ahead and get on the trial, but at the same time, I would make arrangements for genomic sequencing so that you could.
I've had Foundation 1 sequencing. I sent it to Rick. I don't know if there was just a couple of odd items on it. I don't think there was anything particular.
Okay, and so it did not identify anything that looked promising as an actionable mutation.
Correct.
Well, there were a couple things, and they said that there were trials on those, and that's what I went to UC about, and they recommended that I go on this BET inhibitor. They didn't really say much about the other trials.
So,
but you really,
Bill, let me just interrupt for a second. There were two things that were shown. One of which I know is there's an ARM4 in MATCH, which was a P10 loss. So the MATCH clinical trial does have an arm for people that have that variance. And the other one, which I know nothing about, never heard of, is PIK3CA, PIK3CA amplification. So those were the two things that, at least, that Eric pointed out to me.
I don't, you know, it seems like your options are pretty limited, and this is worth a shot, unless you can come up with something else that's better. But it doesn't sound like there really is.
Yeah, well, that's kind of where I am. So.
Yeah. I mean, as Rick said, you can, you know, if it doesn't work, I think you'll probably learn pretty quickly, and then you can start, you know, looking at other options, for other options.
And you know, whilst you're still healthy, one thing to consider is Xofigo, because you haven't done Xofigo yet, have you, Eric?
No.
No. So give it a shot, and you know, give it a shot, and then, you know, maybe start talking with Agarwal or Amy Lynn about Xofigo.
Yeah. Okay. Yeah, that's what my regular oncologist was going to put me on.
Yeah. Who was it that did the Foundation 1 for you? It was your Outer Bates oncologist, wasn't it?
Yes, that's correct. I asked for it. They weren't, you know, they didn't come up with it. I asked. Right. And they had to get the sample from the, you know, I had a prostatectomy, and they had to get the sample from the, you know, from what they had left over. Yeah, but you see,
this is a perfect example. You need a current. You need a current sample. Your disease is changing.
They won't take samples from my spine.
And that's the only place that they see Mets in your spine?
Yep.
Okay. Well, you know.
I mean, that's pretty much the situation for me, Rick. I mean, I don't. Yeah. You know, I don't have anything to work with.
Yep. I got you. All right.
So CTC stuff becomes more and more important as
absolutely,
because that, you know, it's readily available, and if they can't get a sample, they can't do the sequencing.
Right.
It reminds me, my father was a doctor, and he used to tell his patients when they came in with a cold, he says, "You just got a cold, I can't take care of it. But if you don't take care of yourself, you'll get pneumonia, and then I can treat you."
Well, that's good advice. That's very good advice. A wise man. No, patience. You're not sick. You're just pregnant. But that didn't go over very big either.
All right. If I'd like to move on because we're running a little short of time. Eric, again, dialogue with us and with me offline. I can connect you through, but let's go for the BET inhibitor, and let's hope and pray that you get something out of it. As Bill says, it's an exciting new class of drugs.
Yep.
Dennis, are you with us?
Yes, I'm here.
Give us please an update on your treatment, and you said you just finished chemo. Just remind the guys.
Sure, just finished 18 weeks of chemo on docetaxel, and still on the Lupron. And I'm looking forward to, in about 3 or 4 weeks, to having another session with my oncologist to discuss our care plan going forward. And so very much interested in gene sequencing and immunotherapy.
Okay.
As you know, I have advanced cancer with 5 Mets, and it was just diagnosed this year. So I know eventually what I'm up against, and this looks to be one of the more likely scenarios. But difficulty is going to be that I don't necessarily have a known family history of cancer, other than my father, died at age 61 from lung cancer, smoking. So there's little familial history to go on. But the fact that I guess I do have this advanced prostate cancer, metastatic, not yet become castrate resistant, which I assume will be the next step, and maybe we can even head that off if I can get into the gene sequencing and immunotherapy. So that's kind of my hope.
What has your PSA done? I know you told us that it dropped to 1.89.
Yeah, then it went to 1.04 about 4 weeks ago. Yeah, about a month ago. The lowest was 1.04, and the highest was 17. So it's been on a steady decline through the chemo and the androgen deprivation therapy. But I'm anxious to get off of this. I've had enough of the nausea and exhaustion and all the other stuff that goes with it.
Have you managed to play any rounds of golf?
No, I can't. I just can't muster up enough energy. I get feeling good after about 2.5 weeks after the chemo. I feel pretty good, and I'll start working out and exercising and walking and really get to where I'm feeling pretty good. And then I'm back into the next round of chemo.
That is the cycle, as Steve says. Yes, and it's true. But even if you get out onto that putting green and walk around there, it's good enough.
Yeah, I do get outside. In Tucson it's pretty hot, so I got to get out at 5:30, 6 o'clock in the morning.
Right.
And I've done exactly what you said. I'll meet the guys I usually play with up at the course and do some putting, do some light chipping, hit a small bucket of balls. So
great, but that's perfect. Dennis, God bless you. That is exactly what you got to be doing. That is fantastic that you're doing that.
Yeah, I'm looking forward to getting back to it. Big part of my social life.
Dennis, this is Steve. There is a trial that you might be interested in down in San Diego. I think it's a Sharp Medical Center, but you have, if only 5 Mets, you're oligometastatic, and they're trying a trial of stereotactic radiation for oligometastatic, both to the prostate bed plus your minimal metastases, to see if that is a reasonable trial, you might look at that and see, because I think you might be eligible for that, and it would certainly get you off the chemo, that's for sure.
Yeah, I did. Well, I'm all done with the chemo for now. Who knows where I'm going in the future, but I did look at this study. Matter of fact, I contacted two of the doctors. I finally did get a reply from them. But I had to make the decision of I wanted to travel back and forth to San Diego on a regular basis for all of the treatments versus being in my own home. And I got a full care cancer center here in Tucson that I'm happy with. And the other part of it was a double-blind study. So I could have been in it and not really getting the treatment.
Well, it's pretty hard to double-blind radiation, actually. I don't think that is double-blinded. There's no placebo for radiation. I mean, sometimes out of the trial in Tucson, they may look at that trial and say, we're willing to do that if your insurance will cover it. So out of the trial, you might get the same type of treatment.
Yeah.
I mean, Steve,
I was familiar with that. Thank you.
You should know that Steve just got his prostate radiated despite having extensive mets. So I think that's...
Yeah, my testicles glow in the dark now. It's great, you know. I don't need a night.
We should ask what color. Green or orange?
Well, that's better than me. I can't find mine anymore.
I can only find them because they're glowing.
You know, I think that you've got to really demand that you get sequenced, Dennis. I mean, this is, I hate to sound like a broken record, but again, I mean, it's time, and it could well be appropriate. And even if you get sequenced now and get sequenced again a year from now, you're not going to lose anything, as Bill was saying. So, you know, now is the time to get sequenced. If U of A doesn't have the panels themselves, and I know they have a good cancer center, get it over to Foundation One, and let's see if there's anything in there, because that's how we're going to know the right immunotherapy. You know, we can help you if Dr. Singh is a tool resistant. We'll make the arguments Bill has offered, and he's from a highly reputable center, and I've got other guys. I mean, I've got a new guy that I just met who was a friend of Trevor, God rest his soul, who is a senior research VP at one of these biopharmaceuticals and has offered us technical assistance. So we've got some guns that we can bring to this for you.
Okay, that's good to know.
Okay, well, just keep us posted. Let me see. Steve, just give us why don't you talk a little bit about you have to send Haley away, and you have to talk to us about what happened last week.
It's getting near her dinner time here, so I'll see. Well, so Rick's continued urging. Last week I was up at my cabin up at the Russian River, and I rode a Lila rowing scull up there. Rick and I have rowed several times, but I rode about 5 miles, 4.5, 5 miles, and then I began to notice my butt was numb as I rode and wouldn't kind of recover in my perineal area. So I ended up, my wife's urging, calling my oncologist, who I said, well, I'll wait till I get home next week. She said, no, get an MRI now. And so they did an MRI on me that next day, and what it showed is a lesion in the sacral between S1 and S2 that's impinging the spinal cord near the area called the cauda equinus, the sort of the edge of the spinal cord where it becomes, the expression for that is a horse's tail, cauda equinus. So it's compressing some of those nerves and it's causing compression syndrome, and that's why my butt was numb after rowing. And anyway, so the bottom line is the next day I started on spot external beam radiation. I've had now 3 doses of that, and I have 3 more to go next Tuesday, Wednesday, Thursday, and I'll be done. And I am actually feeling better. I'm on some Decadron too, which explains my talkativeness. Anyway, so that's my story. You know, I just finished the stereotactic radiation in the prostate, and now I'm doing spot radiation. My PSA, I did it 5 days after the stereotactic radiation, it went from 23 to 32. But I'm thinking some of that, it could be the lesion on the sacrum, could be just the, it's like doing a rectal exam and your PSA goes up. So if you radiate your prostate, I figure is going to go up also. So I don't know what it's all about, but I'll do another set of panels again in about 3 weeks and see where I am. And now they're talking about putting me on enzalutamide and shortly thereafter on Xofigo. So it's, it is what it is, right?
And
so, I feel good. I won a tennis match yesterday. That was a good match. So that was good.
And Steve has agreed to do whatever it takes to get a to get a biopsy sample that can be sent to Foundation One.
Yeah, I agreed that I go to Kaiser and they agreed with very little argument to send me to UCSF, Larry Fong, and he's going to do a biopsy. Hopefully he'll be able to do one because I don't know where the Mets are. I haven't had a bone scan or CT for quite a while, but other than the sacrum. And so I'm hoping to have that done in the next month or so and have a sequence by the Dream Team. And after our discussion today, I think I'm going to have them send it to Foundation One and get a comparison as well to see if they have compatibility to match.
Okay, thank you. Thank you for any questions.
I was just going to say, I think I emailed you earlier today, Steve, that I had a lesion in about the same place.
Yeah.
And I went through exactly the same spot radiation treatment. I think it was 5 fractions rather than 6. And yeah. I felt an effect after 2, and by the 5th one, I didn't feel anything anymore.
Yeah.
And it had been quite painful. So.
Yeah, Bill, I did see your email. I responded actually, and interestingly, I don't have any pain. I just have this numbness, and the anal sphincter is not, is weak as well. And so, I mean, that's how I've noticed this. And actually, if it hadn't been for Rick encouraging me to row so damn much, I don't think I would have noticed this. Thank you, Rick.
Yeah.
I did buy a cushion for my seat, though. I did buy a little cushion.
Oh, yeah.
I
have this special cushion. I have acute radiation cystitis, and I have a great cushion that's shaped in a particular way. It makes it really comfortable. I don't know if that's what you're talking about. Is for a cushion.
Yeah, this little foam one that I got and Sweep and Skull. It's a website, and I just got it in the mail today, so I'm going to try it out next week.
Yeah.
Thank you, Steve. Anybody else have any questions for Steve on what he's going through?
Steve, if you had an MRI, it didn't show other areas where they could take a biopsy?
It was really looking towards the symptoms, the perineal numbness, and so it wasn't really extensive. On August 17th, I have a full restaging with CTs and bone scans and so on. So I'm hoping they'll find something they can biopsy. I was interested when Eric said they couldn't biopsy the spine because that's where most of my lesions are, I think. So I don't know. I'll have to see on the August 17th what that restaging scan shows. There's nothing in the prostate. The prostate biopsy is completely negative.
Yeah. Which is a good sign.
Yeah, it's like here's first the good news, your prostate is negative, and now the bad news, you can't be sequenced,
Yeah, that is the dilemma.
Yeah.
Yeah.
I think I'm in the same boat, Steve.
Yeah, right, exactly.
Okay. Well, it's right at 7 o'clock. Is there anybody that I have missed who would like to, has anything they want to raise? Or if not, we will close up.
Hi, Rick. This is Richard Foodie. I just wanted to let you know I've been on the call and listening in for about a half an hour or so.
Yeah. So
what's the matter?
So Mr. Foodie, the first hour was very interesting, and I would encourage you to listen to the recording. It may be a bit chopped up. I think at one point we lost a little bit, but you'll get the gist. And thanks to Bill, we got some really good stuff. And And let me just ask you very quickly, were you late because you were practicing your dragon boat racing?
Yes, so the race is on Saturday, and we were rained out yesterday, so they put in a practice today, tomorrow, and Thursday.
So would you like to just share with everybody what it is that, why it is that you're practicing?
I'm wondering if people are familiar with a boat called a dragon boat.
Oh yeah, absolutely.
Okay, it holds 20. It holds 20 paddlers, and you're facing forward, and you're paddling in a competition, and the races are 200 meters, 500 meters, and 2,000 meters. I'm racing. I'm on the Memorial Sloan Kettering team. I'm actually a member of the Empire Dragon Boat team, which is the all cancer survivors team, but the Memorial Sloan Kettering team, they needed extra paddlers for this Richmond race because they wanted to have 2 boats, and so they recruited some of us from the Empire team, and so it's really exciting. I've only been in one race before, and that was in Princeton in June. It's exciting. It's one of the most extraordinary challenges and difficult things I've ever done in my life, you really learn a lot about yourself as well as anyhow, so it's very interesting, and I'm really glad I'm doing it.
Fantastic. Fantastic. More power to you, and we want to report on how you do in the race next week.
Okay, well, thank you.
And maybe we need a Answer Cancer. Maybe we need an Answer Cancer Dragon Boat team. I don't know. All right. Oh, and Richard, I'll drop you an email. I've got to talk to you about getting. We were hoping to get Donna Wilson on for the 5th Monday of August to talk about exercising.
Yeah, she had said that she would be able to do something in August.
Right.
She just came back from a 3-week vacation, so, and then we've got a race in Hartford August 20th.
Right.
So, so the Empire Dragon Boat team, they're gearing up their practices for that.
Okay.
And I'll be racing in Hartford as well. But I'll see her on Wednesday, and I'll ask her about that.
Okay, and let me know, and then we'll organize something for that plenary on August 31st. So, gents, that's it for tonight. It's been a bit of a different session, but I hope you've all found it valuable. And like I say, we'll be posting the transcript or the recording pretty soon, and then I would say either next week or the week after we'll have a similar session to tonight, but we'll be looking at immunotherapy specifically. So good night, everybody.
Good night, Rick.
All right, good night. Good night, Rick. Thank you.
I like it, Eric.
Eric, that's great. It's a great pick, Eric.
I think I saw you in Golden Gate Park once.
Yeah, I think so.
Did I miss something? Did I miss a picture? Oh, yes!
It's a Jimi Hendrix look, you know?
We love it. Fantastic. Okay.
1982.
1982. Okay.
It was a good year.
We love it. Okay. Go feed the dog. Go feed that dog.
I will. Take care, Rick. We'll see you guys.
Okay, bye.
Bye.
Night.
Good night. Oh, Steve, you may have to close. It looks like you're the organizer. You may have to close the meeting and stop the